Hello, my name is Arpitansu, and today we'll be talking about the extrapyramidal disorders, and mostly we'll be focusing on idiopathic Parkinsonism in this chapter. Let's start. So, when I say extrapyramidal disorder, I basically mean that it is a dysfunction which is related to the basal ganglia. Now, mostly the striatonigral pathway of the basal ganglia is affected. We know that there are five nuclei in the basal ganglia: the caudate nuclei, the putamen, the pallidus globus, subthalamic, and the substantia nigra. So, in Parkinsonism, mostly substantia nigral pathway is affected, and this dysfunction leads to the disturbance in the movement and posture of the patient. So, the movement and the posture of the patient is affected. There will be tremor or rigidity kind of abnormality which will be seen in the patient. This extrapyramidal disorder is also called as the movement disorder, and this movement disorder is broadly classified as, according to API book, akinetic rigid syndrome and hyperkinesia or dyskinesia. So when I say akinetic rigid syndrome, the name itself suggests that there will be akinesia, that there will be loss of movement or slowness of the movement, like the bradykinesia, paucity of the movement, and rigidity, the tonicity of the muscle will be increased. Okay, and what all these clinical features resemble to Parkinsonism. So Parkinsonism is basically what? Parkinsonism is basically a kinetic rigid syndrome. Okay, so Parkinsonism, if we want to define, we can also define as Parkinson is a akinetic rigid movement disorder. Okay, and hyperkinesia, also the name itself suggests hyperkinetic, the movement will be excessive, involuntary excessive movement. Now extrapyramidal disorder is again classified as a idiopathic Parkinsonism, secondary Parkinsonism, and Parkinsonism plus. So our focus will be on idiopathic Parkinsonism, which is also called as the primary Parkinson disease. Now, etiology for the other two type of the Parkinson's, which is like secondary Parkinson and Parkinson plus, we will see. For the secondary Parkinsonism, like antipsychotic drugs like haloperidol, phenothiazons, these are very common. Like their chronic use can lead to the secondary Parkinsonism. Some anti-emetic drugs for chronic use can also lead to the Parkinson, like metoclopramide. Lithium can also lead to the secondary Parkinson. Apart from that, the toxins like manganese or MPTP, which is 1-methyl-4-phenyl pyridinium, carbon disulfide, hypoxic conditions, cyanotic conditions can also lead to. In secondary Parkinsonism, you will see that there is a common disease, viral disease, which is leading to secondary Parkinson, which is encephalitis. So encephalitis lethargica, Japanese B encephalitis, or subacute sclerosing panencephalitis. So post-encephalitic patient may have secondary Parkinsonism. Apart from that, some Creutzfeldt-Jakob disease is also very common. This Creutzfeldt-Jakob disease leads to dementia and ultimately death of the patient. So metabolic disease like Wilson, vascular disease like atherosclerosis can also lead to the secondary Parkinsonism. Now Parkinson plus is like secondary to the some other diseases. Like it is a clinical feature of the some other disease. Like there can be progressive supranuclear palsy, corticobasal degeneration, diffuse Lewy body disease, which can be lead to the dementia and all, Huntington disease, Side-Dagger syndrome, striatonigral degeneration and all. Starting our main topic, which is idiopathic Parkinson disease, I want to tribute James Parkinson. So James Parkinson was a London-based surgeon who, wrote a 66-page booklet about paralysis agitans or the shaking palsy, which is the other name of the Parkinson. And as a tribute, this paralysis agitant or shaking palsy was named as Parkinson disease. Okay, so it is named after the James Parkinson, and it is the most common, a kinetic rigid syndrome, and almost 1% of all the adults above 60 years of the age are affected by it. Talking about the sex ratio, both male and female are equally affected. Now moving on to the clinical feature of Parkinsonism, as you can see in this picture, this man, he has a stoop posture. He is like bent forward. There's like forward tilt of his trunk. His face is like expressionless, masked like face, expressionless face, which is called a face masking. There is rigidity present in his muscles. His elbows and wrist are flexed. There are tremors in his hand, like pin rolling tremors will be there. Okay, and his gait, fascinating gait, short steps he has when he walk, and his hips and knees are also slightly fixed, and there is trembling obviously of the extremities. So clinically, this is the first period of Parkinson patient. Okay, and all these symptoms that I talked about, they start insidiously. The major three symptoms that a Parkinson patient present are the tremors, rigidity, and akinesia. These are the three major abnormalities which a Parkinson patient present. Now talking about the tremors, what kind of tremors these Parkinson patient have? So they have resting tremors, which have a frequency of about 4 to 6 hertz. Then they have pin rolling tremors, like the patient has tremors. It is as like he is rolling something in between his thumb and index finger. There's like a rhythmic tremor at his wrist and fingers. Some patients also have like fast action tremor, where the frequency of tremor goes up to about 8 to 12 hertz. And all these, these tremors, they get aggravated when a patient has emotions or when they get fatigued. So these tremors increase. So this was the first major abnormality. Secondly, the akinesia and rigidity syndrome. So the patient have akinesia, there is loss of movement or paucity of the movement or slowness of the movement. And then there is a lead pipe rigidity. The lead pipe rigidity is the hypertonicity of the muscles. And the hand, they get like when you do this, the whole of the hand move up like a pipe, like a lead pipe. And there is like a cogwheeling. So when this rigidity, it is mixed with the tremor, it is called as the cogwheeling. And when you in cogwheeling, when you like push the hand backward, it has a jerky movement, like it goes back like this. And it is mainly the cogwheeling is seen of rotatory movement of the wrist and all. And the face, as we have seen, the face was expressionless, which is called as the mask-like. Glabular tap is often positive. When in a normal patient, when you do the glabular tap, it doesn't blink. But in a patient of Parkinson, if you do the glabular tap, there is like a blinking is present. And obviously, Parkinson is a disease of basal ganglia, whose main function was, the motor functions. So all his motor activity will be slowed. Even the normal household chores will be difficult from here. Like he can't even dress himself, he can't even feed himself. He will be dependent on some other person for all these kind of actions. And other clinical feature will be like when you ask those patients of Parkinson to write something on the paper, his writing will be very small. So there will be micrographia. And his voice, he will be hypophonic, monotonous, and he will be stuttering. And in advanced cases, the speech is barely just a mutter. The salivation will be increased, saporia will be seen and all. Now, talking about the postural instability, as we have seen the Parkinson patient, there was like a stooping of the gait. Okay, so the patient was stooping, and there was like pronounced kyphosis, stooping, and kyphosis of the spinal cord will be present. And we have seen that there was, the flexion at elbows and the wrist. Flexion was also present at the joints of the legs. The patient will have difficulty once he sit down. He will have difficulty standing up. Now, the main point over here, we have to know what is a pull test. Now, in a Parkinson patient, when he is standing in a standing position, if you like pull, if you go back to the patient, you hold the shoulder of the patient and like pull him back, suddenly pull him back. So normally, what happen if you are normal, if in a normal healthy person, when you hold the shoulder of the patient and you pull him back, he try to balance himself to fall back, but that is absent in Parkinsonian patient. So there's like a retropulse and the patient fall back. So in Parkinsonian patient, when you hold the soldier and you pull him back, the person fell back. So that is a pull test which is seen, which is done in a Parkinsonian patient. And we have seen the gait was slow and shuffling gait was present. There was like fascinating gaits was present, short gaits was present. Uh, there can also be, the noticeable limp may be present, and freezing may be present, like freezing. So the patient, because of the freezing, may fall forward. Now, apart from the motor actions, some autonomic and sensory disturbance will be seen. Like there will be some autonomic disturbance like constipation, nocturia. These can be seen. This orthostatic hypotension is usually seen because of the anti-Parkinsonian drugs that the patient take. As a side effect of those anti-Parkinsonian drugs, this orthostatic hypotension is very commonly seen in the patient. The sensory disturbance will be also present, like depression will be present, anxiety, sleep disturbance, and cognitive disturbance may be seen in the patient. Now, what is the basic pathology of a Parkinsonian patient? So, it is a disease of the basal ganglia, dysfunction of the basal ganglia. So, there is a degeneration which is seen in the nigrostriatal tract. So, where does the nigrostriatal tract start from? The nigrostriatal tract starts from the, substantia nigra pars compacta up to the, to caudate and putamen of the forebrain. And the degenerating neurons, they produce Levy bodies. So what are Levy bodies? Levy bodies are basically aggravated, protein bodies. And these are like getting deposited in the brain, like nigrostriatal tract and the basal ganglia. And these are also seen in the dementia patients. So there's like a diffuse Lewy body disease and also. So degenerative neurons contain Lewy body. And these are very highly sensitive marker for the Parkinson disease. Apart from the basal ganglia, Parkinson also affect other parts of the brain like olfactory center, lower brain stem, thalamus, and cerebral cortex. Now we will see that how it affects, because it affects the lower brain stem. What are the symptoms which will be seen? Like okay, then neurotransmitter we will talk about. There's like depletion of dopaminergic neurons in the substantia nigra, which result in the striatal dopamine. So there is a deficiency of dopamine. Normally there is an equilibrium between the acetylcholine and dopamine, but what happens because of the deficiency, depletion of the dopamine, the acetylcholine increases, okay, and this acetylcholine increase will lead to the symptoms of Parkinsonia, okay. So normally there is just an equilibrium between the acetylcholine and dopamine, and dopamine deficiency lead to acetylcholine hyperactivity. Now we have seen previously that apart from the basal ganglia, uh, apart from the basal ganglia, the lower brainstem was also affected in Parkinson. So locus careolus was affected, raphe nuclei, and this basilis of the Maynard, nucleus basilis of the Maynard was affected. And because of these, the freezing, depression, and dementia are seen in the Parkinsonian patient. Some genetic factor also usually work. The protein alpha synuclein PARK1 gene and PARK2 gene. Apart from that, the LRRK gene, which is the leucine rich repeat kinase, is also affecting etiology of the Parkinsonian disease. Now, what are the investigation you will do? Obviously, CT scan and MRI will be done, and they will show that there are variable degree of atrophy of the part of the brain. Apart from that, we can do the PET scan or DAT scan, and we have also SPECT like a single photon emission computed tomography. So it is also CT, but single photon emission computed tomography. Now, coming to the treatment part. So primary line of treatment is, the physiotherapy and exercises and all are to be prescribed to the patient. And once the physiotherapy has been started, we can also add supplementary, additional drugs. So the drug of choice for the Parkinson is the levodopa. Levodopa is a drug of choice, but levodopa is not given alone. It is usually mixed with decarboxylase inhibitors like carbidopa or benacerazide. Okay, so levodopa is usually given with the carbidopa or benacerazide. And usually in API it say that whenever a Parkinson patient comes, because levodopa has very side effects. As you can read, anorexia, nausea, vomiting, postural hypotension, a lot of side effects has been, counteracted by the decarboxylase inhibitor like carbidopa and benacerazide. But still, when the Parkinsonian patient comes first time to your clinic, you should start with salicylic 5 to 10 milligram, or we can start with the amantadine 100 to 200 milligram. Apart from that, we have also have a COMT inhibitor like entacapone, tolcapone. These are drugs which can be used, and anticholinergic like trihexyl phenadiol can be also used. Now for symptomatic treatment for like tremors or tremors and all, we can use benzodiazepines and all. So, and we have some other dopaminic agonist like bromocriptine, ropinirole, and pramipexole. As we have seen that dopaminergic neurons were depleted, so we can use dopamine agonist, bromocriptine, ropinirole, and pramipexole. Okay, so this was all about the Parkinson. Thank you.